for Dr. Beshiri.
Thank you very much, and it's a pleasure and an honor to be here. I'd like to thank Dr. Reddy for the invite, and hopefully we can share a little bit of the information that we have on the cardiac registry so far. I'll start with why we're here. This was a recent article that was published with cardiologists around India talking about cardiovascular disease prevention, and in some cases specifically heart failure, but the biggest need for India being a cardiac registry. And some of the attendees were actually Apollo cardiologists. So we do have one common objective. We know that per the WHO, cardiovascular disease is the leading cause of death globally. And in India, according to your own data, people die of cardiovascular disease 10 years younger than the West. So it's an even more pressing matter and pressing clinical matter in India, and that's why the initiatives and the vision of Dr. Reddy is happening. But we started this journey 2.5 years ago when we first met Dr. Reddy. And we also met the core team, Dr. Sangeeta Reddy, Dr. Hari Prasad, and the rest of the team, where we discussed primary prevention of cardiovascular disease. And I was inspired. I was inspired by Dr. Reddy's vision in other areas, but also in cardiovascular disease prevention. If you learn anything from today's talk, and most of you know since you're cardiologists, our approach is utilizing a cardiac-specific biomarker. A cardiac-specific biomarker that has been long used in the acute setting, and we spoke about acute interventions earlier, telemedicine and the ECG findings almost immediately across the internet, which was very impressive. But here we're talking about troponin, or the high sensitivity version, being used in the general setting, in the general population. So high sensitivity troponin is not a necrosis marker. It is primarily a cardiac injury marker. And cardiac injury happens in the general population as well as in the acute setting. How much cardiac injury will lead us to knowing if there is necrosis or not. So, if anything, please remember high sensitivity troponin is a cardiac injury marker, and this is coming from the universal definition. ESC, AHA, ACC. So after 10 years of development and research and publications, we presented all this data and all these publications to Apollo team. And then we presented our validation data. But then we also wanted to figure out if that data, since there was no Indian data in these publications, was also applicable here. So Abbott and Apollo first journeyed on the first collaboration of the pilot study to run all the Apollo staffs and determine if risk stratification with high sensitivity troponin was applicable with those same cutoffs that we have validated and CE marked. And of course, the established cutoffs are on the screen here. It is the leading ACS assay, and Dr. Hari Prasad and I are also working on AI algorithm for the acute setting with this same assay. There's over 200,000 subjects in publication showing risk stratification works. Validation has been done, and when we started, it wasn't even CE marked yet. So the vision that was presented was very early. But yet the need now is clear, and that journal publication or that magazine publication shows it. And today we are CE marked. It is regulatory registered. So what we envisioned was that the leading sites at Apollo would utilize and implement high sensitivity troponin in their health checks and in these staffs, transfer that data to a registry and selected samples to a biobank. And then, to make this more of a national endeavor, Apollo also agreed that we would allow other institutions, if they were willing to follow the Apollo protocol, which would be optimized, and of course leading the effort, to join the registry. So that could be a national registry as well. So what are we collaborating on? We're collaborating on a cardiac registry for primary prevention that for the next 10 years, utilizing high sensitivity troponin, in addition to everything else you already do, to improve outcomes and increase prevention. Of course, this research will lead to a lot of publications and studies that will be ongoing, the education for internal, national, and I hope to see international endeavors pretty soon once we start publishing. And this is what leads to guidelines. So visionaries like Dr. Reddy are what champion early research, what champion early implementation, and would lead to national and international guidelines in the future. Where we are today. Well, this is the registry so far, and I have to tell you, most of these are Apollo staffs, but we're already above 30,000 subjects in the cardiac registry. Going across the sites, the 6 main sites of Chennai being the leading site with health checks, Hyderabad, Kolkata, Mumbai, Delhi, and Bangalore. And of course, we've spoken with the Apollo team and Dr. Ari Prasad, and this will be pan-India. So I hope to see this going into the millions within that 10-year time frame. Very unique for a cardiac registry. Globally, it would be the largest ever. It also includes a biobank. Therefore, any new discoveries, any new research, we have the matching samples of that subset to go back and validate, which no cardiac registry has today. So, potential for a national registry, and I envision a global registry. As I travel the world, in my last discussion with Dr. P.C. Reddy, there are other countries that are very interested in this type of a registry. Russia, Scotland, New Zealand, Kazakhstan, and the US. So follow-up is key. Remember, high-sense troponin is a cardiac injury marker. If there is no injury today, we also want to make sure there is no injury tomorrow. If there is a lot of injury today, and we have intervened, we want to make sure that that injury has decreased, therefore decreasing cardiovascular risk. So this is an example of some of the follow-ups that have happened, and this is primarily coming from the Hyderabad site. And we see that there is a proportion of individuals that have gone from high risk to low risk. And that's great. I'd like to see what the intervention was. Can we replicate that intervention? And can we maintain that patient in that trajectory? But unfortunately, the higher proportions end up being going from low risk to high risk, from moderate risk to high risk. And there, we probably have not intervened. A lifestyle change, anti-lipids, antihypertensives, and possibly a more severe intervention may be needed, but we have not done it. Or what we've done is not good enough. So follow-up is key. And that depends on all of you. Because the moderate and the high risks, they should be referred to cardiology. So if we were to go into the cardiac registry, we can pull up any one of those cases. This is a high-risk case. In fact, it came in as a low risk the year before. So it's a fairly young male, 40 years of age. And if we look at some of the variables, some of the parameters, it doesn't look like a very high-risk patient. Hemoglobin A1C, of course, is elevated, but the lipid profile is not remarkable. And you can see the history and the family history. Let me go back one. But they went from a high sensitivity troponin result that was very low and was considered low risk to a high sensitivity troponin result that is high risk a year later. So whatever we're doing in managing this patient, we are not managing them optimally to decrease their risk. What high-sense troponin is telling us is that we are seeing more cardiac injury over time. And where's that cardiac injury coming from? Because of the hemoglobin A1C, and the type 2 diabetes, it's a possibility that is coming from rigidity or unstable plaques and micro events. So maybe a statin is also needed here, even though their lipid profile doesn't call for one. But you know, statins have more impact than just decreasing and normalizing or lowering your lipid profile. They also sheathe and protect unstable plaques. So this is what we have to look at and be very careful when we're looking at patients that have changed over time. Follow-up is key. You saw this already, I don't want to belabor the point, but when high-sense troponin is low risk, according to your risk calculator, which may be low, moderate, or high, and high-sense troponin is saying it's low risk, yes, treat them for their underlying comorbidities, for their underlying disease, treat them for that. But there is unlikely cardiac injury happening in that patient. When high-sense troponin is telling you there's a moderate risk of cardiac injury, again, you would follow what your guidelines say for that risk level according to your calculator, whether you like Q-risk, you like Framingham, you like SCORE from Europe. But there is moderate injury. That moderate injury needs to be investigated. And then when there's high risk, this is the patient you really want to consider for obviously an ECG, treadmill stress, echo, maybe CTA or CMR if you have it available. Because if they're low risk by your calculator and they're high risk with high-sense troponin, that injury is coming from somewhere and there is no other indicator that is telling you to do additional workup on that patient, especially imaging. I'll stop there. Thank you very much.